Good evening, everyone, and welcome to CornerStones Best of DDW in IBD 2022 for Australia, Part 2 webinar. I'm happy to introduce tonight Professor Susan Connor and Associate Professor Miles Sparrow, who'll be bringing you our Best of DDW program.
So my section tonight is current and emerging therapies, biologics, biosimilars, and de-escalation of biologics. Some really exciting data here. This is probably about half of our slide deck tonight. We've focused on some really interesting investigator-initiated studies, actually, which all came into the top 3 studies that we thought of at this year's DDW that Susie will summarise at the end. Then there's some interesting data on the newer class of biologic therapies that may be with us soon, the IL-23s, and then finishing with some work on combination biologics, which is perhaps one of our next frontiers. So one of our 3 highlight studies was this study, the SPARE trial. This was a study that was presented by Edouard Louis from Jetaid. It was a European predominantly study, but with some centres in North America and also Australia. John Ding's been involved in the study design here. This was a Crohn's disease withdrawal study. This was looking at patients with Crohn's disease treated with infliximab and azathioprine. They'd been on combination therapy for at least 8 months. They were in a sustained clinical steroid-free remission for 6 months. It wasn't necessarily an objective deep remission. And then patients were randomized in 3 arms to either continue combination therapy, to stop infliximab, or to stop the immunomodulator or antimetabolite, as it's called in this study. The 2 co-primary endpoints were relapse rate over time. This was a 2-year study, and these were clinical outcomes. They were looking at CDAI and development of fibrostenotic or penetrating complications. And then the second endpoint was the overall time spent in remission during 2 years. This was a nice sample size, 200 patients, evenly in the 3 groups. What we can see here, if we turn to the figure up on the right for the first endpoint, patients who stopped infliximab did relapse more commonly. And you can see that actually 40% of patients relapsed over the 2-year period. But if we look at the other co-primary endpoint at the bottom, and very much the glass half full component of this study is that the time spent in remission amongst the 3 groups was both remarkably high and equal within groups. If we look at combination therapy, 1.91 out of 2 years spent in remission. Those who stopped infliximab, 1.89, who stopped immunomodulators, 1.93. And the reason, despite the infliximab patients relapsing more frequently, there wasn't a difference in time spent in remission, is that retreatment rates, success rates were very high. In particular, what was remarkable that of the infliximab patients who flared and were retreated, 22 out of 23, which is 96%, responded to retreatment. Only a minority of patients overall were treatment failures. There were no new safety signals. So what we can conclude here is, although most of us may preferentially choose to stop the immunomodulator for safety reasons in patients on combination therapy, if for whatever reason, be it clinical or even economic, we do need to stop the anti-TNF agent in the form of infliximab, it does seem that this is a feasible strategy, especially when you look at the very high retreatment success rates. So this was, excuse me, this was one of our top 3 studies that we thought, the SPARE trial. This has been currently submitted to Lancet Gastroenterology for publication. 2 studies now on subcutaneous infliximab. This is a molecule that we have now. So this is a biosimilar. The intravenous form is Inflectra. The subcutaneous form is Remsima. This is the study by Philip Smith from Liverpool in the UK. This is a retrospective multi-centre cohort study that was triggered by COVID. And at the start of the pandemic, when the feeling was that we really wanted to do what we can to keep our patients out of hospital, including infusion centres, they switched patients to subcutaneous infliximab and then followed them out for 12 months. This is predominantly a clinical study. They looked at, it was a mix of Crohn's and UC, so the endpoints were Harvey-Bradshaw and SCCAI. They did biomarkers and drug levels as well. The primary outcome was treatment persistence on the subcutaneous infliximab formulation at 12 months. Nice study size, 180 patients, about 2/3 Crohn's disease and 1/3 ulcerative colitis. The vast majority of this cohort was switched to the regular dose of 120 milligrams alternate weekly. There was clinician discretion to switch to a higher dose if patients were on higher doses of IV infliximab, but only about 10% of patients received a higher dose. Overall, treatment persistence was very high. At 12 months, it was 92%, meaning just under 8% of patients stopped, flared and failed and didn't persist on the subcutaneous infliximab at 12 months. What we can see with the drug levels, what happens, and we'll talk a little bit more about this with the next study, the drug levels do go up when you switch from intravenous to subcutaneous infliximab. Median levels here went from 9 to 16 as early as 3 months. That rise was sustained over a 12-month period. What we see at the bottom, this was a lot, it wasn't powered as such. It was effectively a non-inferiority study, and you can see we're just looking to see that patients don't get worse. And if you look at the table on the bottom left, you can see from baseline, 3, 6, and 12 months, disease activity indices and biomarkers didn't change. If anything, there was some subtle improvement. So the conclusion of this study was that treatment persistence was high in this cohort of patients, predominantly who were on standard dose maintenance infliximab therapy. And I should have mentioned that obviously these patients were already on infliximab, they were in remission before they were switched. Another study that we've highlighted just on the bottom right here by Xavier Roblin, a study design that was based very similarly on Mark Wood's IVAC study that looked at excuse me, measuring adalimumab levels with the question of, do you really need to measure these at trough? What Mark showed was that the level is very stable for the first 9 days and then does drop off a little bit to trough. But what Xavier showed that with subcutaneous infliximab, which is also given every 14 days, and he picked 2 14-day time periods and measured the drug levels at 3 points during that time, and it was a straight line. There was no drop or no change over a 14-day period, meaning that one of the advantages of this subcutaneous infliximab molecule is that we can perform therapeutic drug monitoring at any time. We don't need to measure it at trough. Another study on subcutaneous infliximab is REM switch. This was again one of what we thought was one of the top 3 studies of the meeting. This was presented by Anthony Buisson from France. This was a multi-center cohort. Again, this was taking patients who were on intravenous infliximab and switching them to subcutaneous and following out to 6 months is what was presented at the meeting. We can see the study design here at the top right here. Patients on any of these infliximab regimens from 5 milligrams per kilogram 8 weekly through to 10 milligrams per kilogram 4 weekly were switched to subcut at the standard dose of 120 milligrams alternate weekly, and then they were followed up at time points that roughly coincided with when their 8 weekly infusions would otherwise have been. They measured disease activity indices, biomarkers, and drug levels. They looked at the outpoints, the primary endpoints here were clinical relapse, which was either clinical, and they also looked at biochemical relapse with calprotectin and also drug levels. So this was about 130 patients. They'd been on an infliximab for 5 years again. These patients were well, they were in remission. The thing here, and the thing that is novel about this study, is that the majority of patients were receiving higher than normal registration dosing of infliximab. In fact, only 44% of patients, as we can see here on the left, were receiving 5 milligrams per kilogram 8 weekly. The other majority of patients receiving high doses, including some really high doses, 10 milligrams per kilogram 6 and even 4 weekly. About a quarter of the cohort were on immunomodulators. That's perhaps less than we would in our practice here in Australia. Let's look at some results, and this is the figure in the center at the bottom here. Let's go straight over to visit 3. That's out at 6 months. So the obvious outlier is the red group. This is the group that received 10 milligrams per kilogram 4 weekly intravenous infliximab before switching to subcut. This group fell over. They flared early, and progressively by 6 months, 2/3 of patients had relapsed. All of the other groups did well. Let's look at our standard dosing group in green, 5 milligrams per kilogram 8 weekly, a 10% relapse rate at 6 months. That's a good result. I do have some subtle concerns about this. If we think that maybe we'd expect loss of duration or loss of response with intravenous infliximab in the order of maybe 13% per year at most, here we're seeing 10% relapse at 6 months. It's even higher for the 10 milligram per kilogram 6 weekly, not surprisingly. So I think these are very strong data, and they were certainly presented as such, but I do think we need some more prospective studies to have as much confidence with this molecule. These, they also showed a similar increase in drug levels when switching from IV to subcut. The initial drug levels were about 9 and increased to about 16 on subcut. The patients that did relapse, they could recapture by increasing the dose to 240 milligrams alternate weekly. They recaptured 80% of patients into deep remission. And when they did their multivariate analyses, the patients that did relapse were those that were on the 10 milligram per kilogram dose initially, and those that weren't in deep remission initially by a calprotectin of greater than 150. I think these are great data. They're exciting. This is a sick cohort of patients that are needing IV infliximab. I think we need some more prospective data here with some bigger sample sizes as well. A comment that I'll make on the drug levels, it's very appealing to think that just by switching from IV to subcut, we're getting an increase in level from say 10 to 16. We're not comparing apples to apples when we do this. What we really need to look at is the area under the curve as measured by exposure. And the group that's done this is Get Haynes Group from Amsterdam, and when they looked at comparing IV to subcut, there was an increase in exposure with the subcut drug using both at registration doses, but it was in the order of 20 to 25%. It wasn't this dramatic increase that we're seeing in the actual numbers. I think what we're going to end up is with the second normal range for the subcut, a second therapeutic range to aim for, but really exciting data. Some data on vedolizumab now, the Interpret trial. It was presented, it's a study designed by Mark Osterman, who subsequently moved to industry. This was presented by Andres Urrua. This was an ulcerative colitis induction therapeutic drug monitoring study with vedolizumab. And the question they were asking is, to patients who are not responding early, do they just need more drug? Are they clearing drug too early, and do they need more drug? So what they did, this was an ulcerative colitis study. This is by definition, it's a drug that's on market, so it's a phase 4 study. These are usual inclusion criteria for moderate to severe refractory ulcerative colitis. All patients who were enrolled received 2 doses of intravenous vedolizumab at week 0 and week 2. Then they looked at week 6 at responders. And the first comment to make is that 48% of patients had responded by week 6, which is a good result for vedolizumab, which we think is perhaps a slower acting drug. But then they focused on the non-responders, and then they asked the question, is it because they're clearing drug too quickly? So what they did is they actually took their drug level from week 5 and used a high cutoff of 50. That's a high cutoff. Most of the data with Vedo suggests that a level at week 6 of about 30 equates with remission at a year. If the patients had an adequate level, they were just continued standard of care. This study wasn't interested in that. They were interested in the patients with a lower level, and they took them, and if we see the figure at the bottom left, and then randomized them to receive either vedolizumab at standard dosing or vedolizumab at higher dosing. Then there was 2 dosing regimens based on whether the level was 30 to 50 or less than 30. You can see they're talking about really high vedolizumab doses here. As a maximum, if the level was less than 30, they were giving 600 milligrams at week 6, then 600 milligrams for weekly. The primary endpoint was endoscopic healing at 6 months or at week 30. We can see here, looking at the table over on the right, these are relatively small groups, about 50 in each group, but otherwise they were well matched. But we can see there was no difference in endoscopic healing, which I think is the preferred term, which is the primary endpoint, and in any of the secondary endpoints. So that the conclusion here that they made was that actually 48% of patients had responded by week 6, but in non-responders with high drug clearance, they didn't benefit from extra drug. I guess they just need more time. Perhaps slightly counterintuitive to what we may have thought, but some positive aspects of the study, we're not needing a lot of extra drug in induction for vedolizumab. The more vedolizumab data, and Simon Travis presented the EARNEST trial. This was the third of what we thought of were the top 3 studies for DDW. Most of us would now consider vedolizumab as our first-line biologic in ulcerative colitis. pouchitis is just such a tough beast. It's the most common, complication in probably at least 50% of patients after a pouch. We use antibiotics, but what about the patients with chronic antibiotic refractory pouchitis for biologic therapy? This was a multi-center RCT, again, by definition, using a registered drug, so it was phase 4. It was in adults who'd had a pouch for ulcerative colitis and had active chronic pouchitis. The primary endpoint was the Modified Pouchitis Disease Activity Index. This is the Pouchitis Disease Activity Index, or PDAI, without histology, so it was nice and simple. It was a 1-to-1 randomization. Patients received vedolizumab at standard dosing or placebo. Importantly, all patients received ciprofloxacin for the first 4 weeks. If we look at the figure over here, in the middle, the primary endpoint, which was relatively early for vedolizumab, a significant delta between vedolizumab and placebo, that at week 14, maintained to week 34, and then moving through other endpoints. Response was great and was high. And then the PDAI remission rates over on the right, which includes histology, also significant results. So this study really met all its primary and secondary endpoints. There were no new safety signals, and vedolizumab was superior in achieving clinical endoscopic and histologic endpoints. What's happened on the basis of this, and I'd love to think it follows here, is that vedolizumab is registered as the first biologic agent for use in the EU for pouchitis independently, which is a great advance. Let's look at perianal fistulas now and some data on ustekinumab. These are post hoc analyses. Susie and I have tended to not include a lot of post hoc analyses in this data set unless they're very clinically relevant. We felt that these were. This was looking at fistula outcomes in Seaview and Stardust, which are 2 one-year ustekinumab studies. We know Seaview, which was in biologic naive patients randomized to Stelara or adalimumab. Fistulas were recorded throughout the study, evaluated at baseline in week 52. For Stardust, which is the open label ustekinumab study, which has some TDM components, some intestinal ultrasound, fistulas again evaluated baseline in week 48. For this post hoc analysis that was presented by Bruce Sands, they used a very strict definition of fistula resolution of closure of all fistulas, so a tough endpoint, but the results were very encouraging. In Seaview, 54% of patients achieved complete fistula closure with ustekinumab. Interestingly, that was higher than with adalimumab, which is perhaps a little counter to what we might have thought. In Stardust, 47% rather, of patients achieved fistula resolution. So overall, half of patients in Seaview and Stardust had fistula resolution after a year with ustekinumab therapy. I think we're all going to go to an anti-TNF first, but with these data, it gives us some confidence about ustekinumab. With the Enterprise data, also there's some confidence with vedolizumab as well. So all is not lost after anti-TNFs for perianal fistulas. One thing I'd caution you to here is the numbers are really small. If we look at in Seaview, we're talking 13 patients, and in Stardust, 19 patients, but some nice signals that we're seeing. The next class of therapy that we'll get, next biologic class, is the IL-23 drugs. There are 4 of these drugs in development. The first drug that we will receive is in ulcerative colitis is mirikizumab. This is Eli Lilly's molecule. There'll be a new new company to work with in the IBD space. Their development program is called Lucent. Lucent 1 is induction, Lucent 2 are maintenance. These are really nice data, which we present because we think this will be the first IL-23 we'll have for UC. This is a phase 3 RCT. It was a 3-to-1 randomization to drug or placebo. Something about the IL-23 class is that the induction therapies are given intravenously, the maintenance therapies are given subcutaneously. There's a lot of variability, and it's a bit hard to remember exactly what all the different induction doses are. For mirikizumab, it's just 300 milligrams every 4 weeks. This was an ulcerative colitis study with typical inclusion criteria. Lucent 1, we're talking about induction, so we're talking at a week 12 endpoint with clinical remission. Although that's clinical remission, it's using a Mayo score, so it's endoscopic. It includes endoscopic results. We need to remember that. You can see here in the figure over onto the left, for the primary endpoint of clinical remission at week 12, a significant delta of drug mirikizumab over placebo. Worked in both biologic and biologic naive and failure patients, but only achieved statistical significance in biologic naive patients, and no significant safety signals that we're seeing over on the right with low incidence rates. There are theoretical reasons by which blocking only P19 and therefore IL-23 is actually safer than blocking P40 and blocking IL-12 and 23 as ustekinumab does. So for mirikizumab for induction, we've got some positive data here. What about LUCENT-2, which is maintenance? We can see the study design at the top left here, a randomized responder study, randomized 2-to-1 to drug. The dose here is 200 milligrams, it's 4 weekly. We can see the results over on the right. For clinical remission at the top, a really nice result of almost exactly 50% of patients achieving remission, significantly greater than placebo. At the bottom, we've got endoscopic and histologic endpoints, and again, some really nice results. The IL-23s as a class have got very good endoscopic healing results in all of the clinical trials in ulcerative colitis and also in Crohn's disease. We can see these results on the bottom left, and also including histology. Histology now included as a pre-specified, usually secondary endpoint in clinical trials. Some nice data here with this molecule. Another thing that this trial did, which I think is really nice, is they had a pre-specified endpoint of urgency in the trial. Urgency is a symptom, and for those that joined last night, you would have seen that patients really are really bothered by, and that was also improved with drug versus placebo. So some really positive results with this, which we hope will translate to availability of this therapy for us in the probably short to in the maybe medium term future. What about IL-23s in Crohn's disease? Well, we've included the guselkumab, which is Janssen's molecule here, because the Galaxy study is really interesting, is as by definition, has a head-to-head comparison with ustekinumab. This is just, Galaxy 1 is a phase 2b study, so there was some dose finding initially, but what we've got results here out to week 48. There are subsequent results out to week 96, which maintain these extra results. I'm going to move through this relatively quickly, but the interesting part here is that there is a comparative biologic molecule as one of the groups. You can see in the table over on the left, as I mentioned, we've got these 3 different induction doses in blue up the top for guselkumab, then randomized to maintenance of these 2 maintenance doses of 100 or 200 milligrams, and then we've got this comparator arm of ustekinumab. You can see for clinical remission, there's a slight numerical benefit to the IL-23, guselkumab over ustekinumab. It must be said that this phase 2b study wasn't powered to show a difference between all of these groups, but when you come down to the bottom to endoscopy, you're really starting to see a bit of separation with the rates of endoscopic response using a pretty stringent criteria of sort of 40 to 45% versus 30%, no real difference in safety. We look forward to the phase 3 data here for this molecule, but guselkumab is looking positive for us for Crohn's disease. But what we will have first is probably risankizumab. This is AbbVie's IL-23 molecule. The development program, the induction studies were called Advanced and Motivate. The maintenance was called Fortify. These data have been previously presented last year. This is just a post hoc analysis, but Susie and I included it because we think this will be the first molecule in this class in Crohn's we get, and it's addressing some important questions. So what these post hoc analyses, 2 combined here, we're looking at endoscopic outcomes to the drug work in bio-naive and prior biologic failures. These are busy figures and slides. On the green on the left is the induction studies, the orange on the right are the maintenance studies. We can see that in terms of endoscopic response, remission, and ulcer-free endoscopy, there is a significant difference between drug and placebo overall. It is greater in the biologic naive patients, but it is still significant in biologic failure patients. That's at both induction and in maintenance. So the IL-23, these data are very encouraging that we can use it in patients with prior biologic failure. At the bottom, the second post hoc analysis here is this interesting question is, do outcomes differ based on disease location? I think we've all learnt that small bowel Crohn's disease, and especially the fibrostenotic phenotype, is just a different beast. And so what they asked with this analysis was, well, how do patients go depending on their disease location? So if we look at these graphs at the bottom reading from left to right, you can see response rates are significantly lower in ileal disease, which is on the left of these figures, and much greater if isolated colonic disease or ileocolonic disease. I think this is not something that's molecule specific. I think this is something that is the case with most biologic therapies, probably also even most small molecules, but it's important data for us to know about this molecule we'll soon have. Now I'm going to finish my section with two studies on combination biologic therapy. So this is deliberately combining two biologic therapies of different mechanisms of action. This is really a stage of where our field is at that I think will advance pretty rapidly over the next couple of years. At the moment, our issues are reimbursement. How do we get it? We need to work with a dermatologist or a rheumatologist. We've got one ulcerative colitis and one Crohn study to show here. So this is an ulcerative colitis phase 2 study called VEGA. It's a Janssen study, and it's combining two of Janssen's molecules, guselkumab, their IL-23, and golimumab, their subcutaneous anti-TNF. This is based on a murine mouse model showing that blockade of both of these cytokines is more effective than either alone, which is, I guess, relatively intuitive. If we look at the study design at the top right, you can see the combination biologic therapy part is during induction out to week 12. That's the blue box at the bottom. There's patients, it's a 1-to-1 randomization to receive both drugs or either drug. And then the monotherapy phase is during maintenance. If we look at results, and here the results are just induction out to week 12, we can see that there is a numerical advantage to the combination biologic in all groups. It reaches significance over golimumab in the primary endpoint of clinical response at week 12. As you can see, as we move over to harder and harder endpoints, the Mayo score or the modified Mayo score, which is without the subjective physicians global, we're seeing a higher delta between combination therapy and the other groups. If we look at safety down the bottom, the issue with combination therapies, we're combining two drugs with risks, especially of infection. We can see reassuringly here the numbers of infections, even though they were in the combination therapy group, were higher, but were present, but were very low rather. So these are encouraging data, just induction data to date in this trial. And then I'm going to finish with the Explorer study, which is a combination biologic study in Crohn's disease that was presented by Jean-Fred Colombel, a phase 4 study of 3 registered therapies, vedolizumab, which is given for 2 years, adalimumab, which is given for 26 weeks, and methotrexate, which is given for 34 weeks. So this was aimed at biologic naive and relatively newly diagnosed Crohn's disease patients, diagnosis within 2 years. These patients were judged to be at moderate to severe risk of having disease complications. They did that via one of 2 ways. They used the AGA's clinical care pathway, which is a pathway that they developed and an algorithm that was published in Gastroenterology actually a couple of years ago, which sort of signifies which patients are at high risk of Crohn's disease in the AGA's opinion. But then they also used CDPath, the CDPath test. Now what this is Corey Siegel's software, which is a prediction modeling software. You probably would have seen this. We presented it several years ago in this meeting. It's where a patient can walk in and you can say to them, look, given your age, your phenotype, your risk of a complication, if you take an anti-TNF is X%, if you take Veto is Y%, on some modeling that Corey had done. And what's happened in the US is Takeda has bought the intellectual property to that and is now using it in clinical practice. So they use that as a way to say, okay, this is how we think these patients are going to get at high risk of complications, therefore we can justify the risks of combination therapy. Relatively small numbers, 55 patients, mixed phenotype, third of patients on steroids. What we can see for the endpoints, and we're just looking out to 6 months now in this tough cohort, endoscopic remission in a third of patients, clinical remission in just over a half of patients. So the conclusion here was that in these patients, triple therapy produced good results for endoscopic and clinical remission. They've concluded that there's no real safety signals. I would differ with that. If you look in the box in the middle, 36% of patients got an infection, but pleasingly, only a minority, a couple of percent, was serious infections. So I think there will be a place for combination therapy. The issues of safety and how we get it. Let's watch this space with interest. So I think that's the end of my slides. We'll probably, hopefully have some questions here. I'll take a look at these, but Susie, jump in at any time if you want. There's a question from Shoma Dutt, and it's about any issues with local pain citrate. I presume that's referring to subcutaneous infliximab. My understanding is that it does contain citrate, but injection site reactions haven't been particularly common. They do occur, as with any subcut, but it hasn't been a big problem with this molecule. Please send in any other questions that you have. I'm going to, there's a question coming in from Tim Elliott. What I'm going to do, okay. Question from Tim Elliott. Thanks, Tim, for dialing in. In the triple therapy study of patients with biologic naive Crohn's, the endoscopic clinical remission rates don't seem to be much better than previous studies with one biologic alone. Do you agree? Oh, look, Tim, I reckon they are at 6 months. This is at 6 months. It's not at a year. 30% endoscopic remission in a tough cohort at 6 months, I think is pretty good, Tim. I think that is probably better than perhaps anything but anti-TNFs. What we're remembering, this is Vedo, obviously we've got adalimumab, but that's just out to 6 months. Perhaps we might see higher with infliximab. Otherwise, I reckon they are pretty good results, Tim. The issue here is with safety, though, obviously, isn't it? And that's what we, we need to watch this space for and get some longer-term data. I'm going to switch presenter over to you now, Susie.
Okay.
Thanks for your comments, and over to Susie.
Okay, great. So now we're going to go on to, I'm just going to get rid of you, Miles, because I still have you in the middle here.
Yeah,
so I hope I don't lose me. I hope I don't lose you. Can everyone still see me? All right. Yep. Can everyone still see me? Miles, can you just check that? Haven't got rid of everybody.
No, I can. Unfortunately, Susie, I can see me.
Oh, really? Okay, sorry about that. I'll share my webcam. How's that? Is that all right?
There you go. Much better.
Fantastic.
And I'll turn mine.
Sorry about that.
Mine
I
off.
can see you, not anything to do with me. Okay. Anyway, so now we're going to talk about disease activity monitoring, and the first slide, and it's not progressing. Great. There we go. Great, fantastic. All right, so the first study is looking at Nordum, and this is finally a study showing that apart from Palot, this is now an infliximab, showing that prospective infliximab level monitoring during maintenance is associated with superior sustained disease control. This is a prospective investigator-initiated study, multi-centre from Norway, and what they did was they looked at a therapeutic drug monitoring strategy compared to standard dosing. And this is not just in inflammatory bowel disease, it was in a number of immune-mediated conditions, including rheumatoid arthritis, psoriasis, psoriatic arthritis, and ankylosing spondylitis, and also inflammatory bowel disease. So of the groups, there was about a third of patients had inflammatory bowel disease overall. So if you look over on the right, the primary outcome was sustained clinical disease control without disease worsening over 52 weeks. That was the primary outcome. In terms of the two arms, the therapeutic drug monitoring strategy, they basically aimed, if you look over on the right, with to an infliximab level of 3 to 8 milligrams per litre, and if that happened, so they checked the patients needed to be on at least 30 weeks of maintenance infliximab therapy. So it was patients who were already in established maintenance therapy. In patients then who were in the TDM arm, they targeted every time based on their levels. So if it was between 3 and 8, no action was taken. If you go towards the left, if the level was under 3, the dose was increased. And if it was under 2, if they had high anti-drug antibodies, they switched therapy. If it was under that anti-drug antibodies were low T, they increased the dose. And similarly on the right-hand side, you'll see if they had drug levels between 8 and 10, they considered decreasing the dose. And if it was over 10, they would decrease the dose. In terms of patients in the standard therapy arms, the decision to adjust dose was based on clinical grounds. Essentially, there were 454 patients, and as I said about UC divisions down there on the left. And in terms of the primary outcome, there was a 17.6% difference in terms of the disease control between those patients in the TDM arm and those in the standard care arm. So that basically, in terms of disease control, was 74% of patients had disease control in the TDM arm at 52 weeks versus about 56% of patients in the standard therapy arm. And in terms of a subgroup analysis, in terms of ulcerative colitis, remember it wasn't powered for specific for each of the different diseases. There was a significant difference observed in the ulcerative colitis cohort between TDM and standard therapy, but it wasn't for the Crohn's disease group. But as I said, it wasn't powered. And in terms for the subgroup analysis, and safety was similar between the two groups. The next study, the next study is, you'll remember with the PANT study that the genetic carrier status of HLA-DQA105 was associated with higher rates of drug antibody formation with anti-TNF therapy and lower serum drug levels. So this is a single-center study from Tennessee looking at the sort of real-world management of IBD patients. What they did was they did a retrospective analysis of all their patients seen within Tennessee, and they underwent DQA105 genetic testing, which you can get with the HLA celiac panel. They had 129 patients. Most of them had Crohn's disease, and they looked at the rate of anti-drug antibody formation. Of course, there was a cross-section of patients who were both on infliximab and adalimumab, and they found, similarly to the PANT study, there was high rates of anti-drug antibodies in patients who were carriers compared to negative patients who were negative for the gene. In terms of actually the number of patients, the percentages between the patients, it's about just over about 42% of patients in this group were positive, versus about sort of late 50% in terms of negative. So that sort of gives you an idea of the proportion of the patients who are positive for this carrier status. Unlike the PANT study, they didn't find any difference in antibody formation in patients who had immunomodulated use versus not, but this might have been the fact that we know that in the PANT study that we found a stronger difference when immunomodulator use was used in the infliximab group compared to those of the adalimumab group. There was still a difference with adalimumab using immunomodulators, but it was higher in the infliximab group. In this, and of course the numbers were higher in the PANT study, but in this study they didn't find a difference in comparing immunomodulator use in the the positive versus the negative genetic carriers. The other thing was interesting in terms of anti-drug antibody production, in terms of if you're a carrier, you were more likely to develop anti-drug antibodies with the use of multiple anti-TNF agents. So essentially, this retrospective cohort of patients really mirrors the data which was found in the PANT study. The final study for this particular area of disease monitoring comes from Cedars-Sinai in Los Angeles, from Andres Uro, who presented this work, and it's looking at a cross-sectional cohort study of both Crohn's disease and ulcerative colitis patients, and trying to understand the correlation between the use of thiopurines, 6-HTN levels, methotrexate, and then drug levels in both infliximab, vedolizumab, and ustekinumab. And the primary outcome is trough concentrations and anti-drug antibodies in combination versus monotherapy with these three agents, and the secondary outcome was clinical and endoscopic outcomes. So the doses, and the study was conducted for about 5 years, and the numbers of patients were 367 patients. As I said, this is a cross-sectional study rather than a prospective study, and the patients need to be on at least 30 weeks of each of the biologics. They're basically evenly distributed between the three different drugs, and the take-home message from this study is firstly that in terms of combination therapy with infliximab, there were statistically significantly higher drug levels, whether you use methotrexate or whether you used thiopurine. And importantly, in terms of the 6-TGN level, which was associated with improved drug levels, the cutoff based on ROC curve analysis was a 6-TGN of 146. You can see this on the panel on the left, the graph on the left. I should make a note that the doses of methotrexate that were used were the majority of patients were on 12.5 milligrams of methotrexate, a smaller number on 15 milligrams of methotrexate, and the dosing of thiopurines was variable, and as you can see, it's shown there in terms of the 6-TGN levels. In terms of the the drug levels with vedolizumab and ustekinumab, there was no statistical significance in terms of drug levels using combination therapy with either methotrexate or thiopurines, and this is shown over here on the right. In terms of the number of anti-drug antibodies that were produced, there were only 2 patients in the 2 groups, vedolizumab and ustekinumab. In terms of the secondary outcomes, this is corticosteroid-free clinical remission, and there was no statistical significant difference in the vedolizumab monotherapy versus the immunomodulator in both the ustekinumab and the vedolizumab group, but it was the rates were better in the combination therapy with infliximab. So I think sort of in terms of this I think the new sort of take home from this is, was first of all, it doesn't really help us answer like what dose of methotrexate. The Concerto study, which is in the rheumatology data, actually showed no difference between 10 milligrams of methotrexate and 20 milligrams of methotrexate in terms of combination therapy. But as I said, this study, mostly the patients are on 12.5 methotrexate. But I think in terms of the thiopurine doses, a 6-TGN level around sort of 146, and we did present data a couple of years ago showing around a 6-TGN of 125 in terms of optimizing infliximab levels. And again, sort of confirming that that the vedolizumab and ustekinumab aren't as don't require combo therapy. It's the end of this section in terms of therapeutic drug monitoring. Are there any questions? So Miles, I actually can't see any questions. I'm just going to go down. Are there any questions? There don't seem to be any questions. I can't see.
There's a couple. Susie, there's a couple from Georgie Cunningham. Thanks for joining,
Sorry,
Georgie.
Here we go. Yeah, I see. Okay, right. They're small. Okay, is there a target?
First one. Okay, you go, Susie.
No, I was going to say, is there a target level for subcutaneous infliximab we should aim for? Miles, I just wonder if you want to speak to that, because we were talking about that before. We don't actually know the answer to that, I think. Yeah, go on.
Georgie, the simple answer, I think, is we don't know. From the observational studies, the drug levels that they're getting are about 15 or so. From the RCT, that were the Schreiber paper published in Gastroenterology, the levels are about 20. But I don't know that we know that they equate necessarily to outcomes. I think that's going to be the order of magnitude that we have, Georgie, and it's significantly higher than IV, but we don't know yet. As I mentioned, look at the APT paper by Get Haynes group, where they did actual exposure by area under the curve. I reckon that's the best data to date, but we're not sure on that one yet.
I see the other one here you've put in here. Is that from Georgie? I've seemed to have minimised my questions, but have you moved to checking HLA? Sorry, Miles, I can't see the questions very well. I presume the questions are around HLA status.
Yeah, I'll read this one out, Susie. Why don't you have a go at answering? Georgie's got 2 questions here. First one is, have you moved to checking HLA DQA A105 in patients prior to commencing a biologic? That's the first question. What's your answer on that one,
Well,
Susie?
that's interesting. After we, I think we still use combination therapy in terms of, this is obviously was looking in the patients with infliximab and, anti-TNF agents. I actually was discussing this week. I think I might, because it may influence more, I think, in terms, and I'll be interested to see what happens with the SPARE study. We always use combination therapy with anti-TNF agent, and that's subsequent to the PANT study. I think the issue really is whether it's going to change, I think, more about those people we might consider withdrawing or not, and that's based on the PANT study results. And I'll be less inclined, I think, to be withdrawing the immunomodulator potentially in the context of someone who is positive and using infliximab. I'll be more inclined to watch them more carefully when you withdraw therapy. I don't think it changes what we do up front, but I think it may change potentially how we withdraw therapy.
So, Susie, is HLA-DQ A105 testing available in Australia now?
Yes, it is. You can just use it with, it's a standard celiac panel, is my understanding.
Oh, wow.
But that's my understanding. So I was on my to-do list to actually look at exploring that.
Georgie, that is a great question. Fantastic. We should all look into that one. I wasn't aware that it's available. That's brilliant.
Yeah, thank you. I think that's it, isn't it? Another question. Yep.
No, Susie, there's one more from Georgie, which is, do you think the higher immunogenicity we see with infliximab pertains to IV delivery previously, peak and trough levels, and will subcut maintenance dosing overcome this?
Well, yes,
So is
I
it the
think.
peaks and troughs that are driving the immunogenicity, I
Well, I
guess, is
think it's the
Georgie's
troughs.
question?
Yeah, I think it's the troughs that are driving the immunogenicity. It's the
Yeah.
troughs basically. So therefore, it's like that's what drives immunogenicity essentially. When there's only low levels of drug in the body understands that's foreign for some reason. It's that sort of vaccination effect. Large amounts the body doesn't perceive it as foreign, small amounts it does. That's a simplistic way to understand it. So it's the troughs which actually end up creating immunogenicity.
I agree with that, Georgie. I think the term that is being used in the subcut anti-TNF literature is high zone tolerance, that if you stay in a high zone all the time, you're tolerant and you don't develop immunogenicity. I think that is true, and that's going to be one of the really big advantages of this molecule.
Yeah, and it's interesting, that's I think these studies, Miles, that we've presented at CornerStones, is while there are some, issues around the studies and the numbers, I think, in terms of REMS, I think it's certainly changing our practice at Liverpool already, and we're going to be switching more across to subcut. We're also involved in Rupert's study anyway, but I think it's given us more confidence, particularly in the patients with higher, where they're on escalated doses, and of course we'll obviously watch them very closely, but it has given us some more confidence around those patients. Yeah.
There's one more question here from Leigh Gunn. Susie, I might ask this one.
Yeah, please
at
do.
what time point should we test for infliximab subcut drug levels after you start treatment? Remembering that the patients have had they've had at least the 2 IV doses, but when do we measure our first drug level? Do you reckon 8 weeks?
Yeah, well, I think it's the study in the registration trial. It was 8 weeks after, I think. 8 weeks after they actually went on to subcut, I think. Or was it 6? Do you remember, Miles? In my head,
No, I
I've got 8
can't
weeks.
remember that one actually.
I
think like the principle is, probably pretty early though. And as Susie's saying, 8 weeks, which should be, 10 weeks into drug. I think we can measure it early.
I think if you just go back to the original paper by Schreiber, I was actually thinking more also about the issue of when when it's maintenance, when you're in maintenance, and how long after you then. Induction. Yeah, you're right. I don't know early, but I have to come back to the company because I have had this discussion. I just can't remember the answer. Terrible, isn't it? But look at the registration trials again by Schreiber. Sorry.
There's no more questions. Why don't we move on, Susie?
Okay, that's great. So now we're going to talk about disease-related outcomes and pregnancy, hospitalisation, disability, recurrence. And there's 7 slides in this section. So the first one is one of 2 studies from the Cleveland Clinic, and this is looking around intraoperative septic complications after an ileocolonic resection, and does it increase endoscopic postoperative recurrence. So this was, as I said, from the Cleveland Clinic. It was retrospective, observational, and it basically was anyone who had an ileocecal resection between 2009 and 2020, and they defined intra-abdominal septic complications as an abscess or a leak within 90 days of the resection, and then they controlled for risk factors and biologic prophylaxis, and they defined endoscopic postoperative recurrence as a Root-Gert score of greater than or equal to I2B, so it didn't include I2A. And the outcomes were endoscopic postoperative recurrence at the time of the index postoperative colonoscopy, and the time to repeat so the surgical recurrence, which is the time to repeat ileocolonic resection for management of their postoperative recurrence. So there were 535 patients. The post-op follow-up, median post-op follow-up was 5 years. About 9% of patients had a complication, which I actually thought was quite high. In terms of the postoperative prophylaxis, about 80% of patients did receive postoperative prophylaxis within 3 months. About 80% of patients had a colonoscopy within 1 year, and that's 422 patients. If you go to the figure in the middle, we're looking now at that particular data, and the median time for that colonoscopy was actually about 300 days. So in terms of it, essentially the postoperative recurrence essentially was higher in those patients that had septic complications, and that was 59% versus 37%, when that was statistically significant. And as well as that, in terms of the patients who had septic complications, they were also more likely to have surgical recurrence, and this is shown on the right with the Kaplan-Meier curve on the right. So I guess the question is, and they also, this wasn't actually shown on the slide, they also showed that biologic prophylaxis did reduce post-operative recurrence in the setting of if the patient had a intra-abdominal septic complication. I think we can't, this is as I said, an observational study. It doesn't tell us what the cause of this is, and there's obviously, potential confounders in that, patients might have had a more severe phenotype, or more difficult disease control disease, which predispose them to getting a septic complication. But I think it does tell us that we need to, try and avoid complications. Whether there's some change in the microbiome as well, who knows? But we do know that they're more likely to get post-operative complications. I think, based on also, I think, thinking about what Miles talked about last night in terms of enteral nutrition, knowing that that reduces complications, we should be more mindful about trying to prevent post-operative complication, sepsis, in ways we talked about last night, and also then be aware that they are potentially more likely to develop post-operative recurrence subsequently for whatever causes that might be. The second one, I think, is an interesting study, again from the Cleveland Clinic, looking at patients who had an ileocolonic resection, then trying to understand the role of a primary anastomosis versus a diverting ileostomy. And then what they looked at, the primary outcome was post-operative radiological, endoscopic and surgical recurrence of Crohn's disease. They propensity matched, score weighted other risk factors, for the diversion recurrence. And then they looked also, in addition to the primary outcomes of post-op radiological, endoscopic and surgical recurrence, comparing those that had a diverting ileostomy or primary anastomosis. They also looked at the impact of biological timing on the ileostomy takedown in the diverted group. There were 793 patients, of which 535 had a primary anastomosis, 258 had a diverting ileostomy. The post-op recurrence was identified in 57% of patients. And in terms of they propensity matched the recurrence rate, and there was no significant difference between patients that had an ileostomy and people that had patients that had primary anastomosis in terms of radiographic and endoscopic recurrence. However, there was an increased risk of surgical recurrence in the diverting ileostomy group. And they found, and this is shown over on the right with the figure on the right here, that if biologic prophylaxis was actually initiated before the ileostomy takedown, it was associated with a reduced risk of recurrence compared to initiating biologics after the ileostomy takedown. And as I said, you can see it over the figure over here on the right, and that was statistically significant. So, I mean, the question is, I guess, should you start biologic initiation prior to stomal reversal? In patients who have, we haven't done. I don't think it's going to change my practice in this case. Maybe Smiles, we can talk about that afterwards. I guess the issue is, I don't think it's going to change that practice, but I guess it's also, I think it's just sort of made me think, well, is that practice actually right or wrong? I don't know. We've always just thought the fecal diversion was the reason why they got post-operative recurrence. Maybe it's more the other confounders, which are the reasons why this observation is shown here. But I think it's certainly an observation worth taking on. This is, you remember, this is a meta-analysis in terms of trying to understand there've been multiple studies trying to understand the difference between Root-Goetz I2A, which is basically lesions confined to anastomosis, versus Root-Goetz I2B, we actually get near terminal ileal, ulcers, and trying to understand if there's a difference in post-operative clinical recurrence between those two. So is it, that there's been some studies saying that all I2 have an increased risk, but other studies suggesting that I2A does not have an increased risk of post-operative recurrence, and that you can group it with I2A. This was a meta-analysis trying to understand that. There were 7 studies, which and this was done, and there were 400 patients. This was a French study. 53% of the group actually so half the patients just had I2A, and the median follow-up was 4.5 years. And essentially, if you look over here on the right, the clinical post-operative recurrence was basically no different between I2A and I2B. And you can see the results here, and that was 11% and 36% in I2A versus 9% and 47% in I2B out at 5 years, and that was the clinical, and the time to clinical and surgical post-operative recurrence were no difference between the two groups. So based on this meta-analysis, the other thing also to say, that a predictive factor for clinical recurrence, which we know is active smoking, and of course we should always be thinking about that as something to modify in terms of risk factor. So essentially, this meta-analysis now, I guess obviously we haven't looked at exactly how good the studies were that were in this meta-analysis, but again at this point shows that there's a similar risk between those both I2A and I2B. So at the moment we should be looking at all I2 and grouping all I2A and B together in terms of in terms of how we now decide on post-operative treatment subsequent to the post-operative endoscopy. This is target IBD, which is, we put this in, Miles and I put this in just to kind of to revisit the question of histological inflammation and being a target for ulcerative colitis. So this is this target IBD study was describing the clinical characteristics and the subsequent loss of response to advanced therapy in patients who were in corticosteroid-free ulcerative colitis who were in endoscopic remission, and they had an index histological assessment as well. This was a 5-year study, and what they did was a look at the loss of response, which they defined as the presence of endoscopic inflammation, erosion, or ulceration on colonoscopy or corticosteroid use, and the follow-up time was indicated here. So essentially there were 513 patients, and of that a third experienced loss of response, and the median time follow-up was 21 months, but the median time to loss of response actually was a year. And if you can see on the table on the right here, histological inflammation on the index biopsy was associated with a greater risk of loss of response compared to those without histological inflammation. So it comes back again to the question of that histological response is another risk factor for loss of response in terms of another risk factor for loss of response. The only thing about this study and what we've got in terms of the abstract is we don't actually know how they defined histological activity. Did they include quiescent histological activity, or did they only define as active disease in terms of whether neutrophils, etc., on the biopsy, or did they define as absolutely normal was normal, and any histological inflammation was then defined as that? But anyway, bottom line is histological inflammation was associated with increased risk of loss of response. This study does not answer the question, do we then need to act in terms of if there's endoscopic remission, but there is histological inflammation? Doesn't answer that question yet. We obviously need more prospective work in that space to actually understand that question. One of the protective factors was being older. The next study is a question of transmural remission. This is a Portuguese study. What they did was they've shown previously in this multi-center study that 1 year follow-up that having transmural remission was associated with better outcomes. This is now looking at a 5-year follow-up, and we know that endoscopic remission is an established treatment target in Crohn's disease. The question is transmural remission better? So this is, as I said, looking at a 5-year follow-up. What they did was they looked at patients who had an MR enterography and a colonoscopy within 6 months. And how they defined transmural remission was patient had both remission on the MR enterography and remission on the colonoscopy, and that was defined as transmural remission. Endoscopic remission was defined as remission on endoscopy, but not on the MRI, and then no remission was defined as no endoscopic remission. So so that's obviously self-explanatory. There were 333 patients, and you can see across all the outcomes, which was in terms of steroid use, hospitalizations, and surgery, that transmural remission was associated with improvements in outcome across all three outcomes. So in this 5-year follow-up, they were associated with improved clinical outcomes across those three. Now, I guess the question is, does it change what we do? I mean, I think, and maybe we can discuss this afterwards, does it change, if you have transmural healing on you've got endoscopic healing and you still have abnormal? Well, maybe it does. I think this is that putting into question how aggressively we should be thinking about transmural healing as another outcome and how we act on it, even if they've got endoscopic remission at the same point, like in the terminal ileum. These are 2 intestinal ultrasound studies, which I loved, and I'd love Miles to comment, given that the Alfred has experience in this area. The first one on the left is a Dutch study looking at it's a prospective study looking at using how we can use using ultrasound, treatment outcomes, so sort of at the bedside rather than necessarily having to do an endoscopy. And what they used, the outcome measure was the difference in bowel wall thickness at week 6 between patients who did or did not have endoscopic improvement between week 8 and week 26. There were 53 patients, so it's a small study. The patients initially had a bowel wall thickness between 4.87 plus or minus 1.23 millimetres. What they found was that a bowel wall thickness of less than 3 millimetres at 6 weeks predicted Mayo zero endoscopic remission at week 18, which I thought was which is fantastic. And they also found that a 23%, so if you're following the bowel wall thickness, a 23% decrease in bowel wall thickness was accurate to determine a decrease in Mayo by greater than or equal to 1, so that it actually can predict the change in endoscopic score. What I thought was also really interesting is that the bowel wall thickness can be specific to the drug. So what they found was, and this shows the graphic in the middle here, that if you're on infliximab or tofacitinib, there was a statistically significant reduction in bowel wall thickness by week 2, but then vedolizumab, this did not occur until week 6, and this is very nicely shown here with that graphic there on the middle here. So I think, we may, in fact, in the future be able to use endoscopic ultrasound as a bedside tool to actually see how well our ulcerative colitis patients are going with their treatment, and using bowel wall thickness as a way to assess this. The second study on the right is from Emma Calabresi in Spain. It's looking at trying to understand how ultrasound can be used and comparing it to endoscopy, and then seeing if we can use ultrasound on its own to rather than endoscopy, essentially, and looking at basically in this study the correlation between intestinal ultrasound and endoscopy. They had 53 patients, and what they found was there was a moderate agreement observed between mucosal healing on endoscopy and the ultrasound, but unfortunately in 4 patients the ultrasound showed that the scope was normal. It was normal on the ultrasound. There was lesion healing, but the endoscopy revealed mucosal lesions still in the rectum. So ultrasound is clearly very good, but in a small proportion of patients, it's not good in terms of actually looking at the rectum. So in patients where they might still have symptoms, but there's the inflammation is isolated to the rectum, the ultrasound is not as good at detecting it in that context. And this is our final slide, and I absolutely love these studies. These are 3 studies looking at artificial intelligence, and we put this in because we just want to sort of look towards the future. And the first study on the left was presented by Laurent Perrin-Bourrelet, and it's looking at using artificial intelligence. I particularly like this study. Looking at what they did was they trained the machine to actually using experienced histopathologist and using the Nancy index in ulcerative colitis, and actually train the AI system to look at all the images and then to learn how to actually to read the histology. They found, you can see just on the graphic down on the far left-hand corner here, that there was a very good intra-class correlation between histopathologists, and that was 89.33, and comparing that to the AI tool, it was actually 87.20, and this is on early days. So, of course, the more you teach the machine, the better it gets. I think the other really interesting thing about this was the time it took for the computer to actually measure, to actually read the slides, was about, it saved enormous number of hours in terms of the amount of time that they saved in terms of reading the actual slides. So I think that's one thing to think about in the future, that we could actually maybe save. It was incredibly time saving anyway. So that's, as well as being very good in terms of correlation. The second study in the middle is looking at assessing Crohn's CTE, CT enterographies, and looking at comparing it with expert radiologists. And they looked at teaching the radiologists teaching the machine how to actually read the MRIs, and they found very good agreement between radiologists and each other, and then also with the machine learning prediction. The other thing I thought was really interesting is because the computer can look at cross-sectionally at the ileum and actually just count all the different sections of inflammation. They developed this score called the SCIDSS, which I can't remember exactly what it stands for. It was a cumulative ileal disease score. And what they could do is actually then, using that cumulative score, actually predict patients which were going to undergo surgery within the next 3 years. And that they could predict that was 46% versus 30% based on the imaging that the machine could actually read by looking, measuring and then counting it up. So I think that's also very exciting for the future. We might be able to use computer analysis to actually be able to predict in the future. And finally, this one was also exciting. I went to this study. There was not many people there, but I just loved it. In the session, the final one was looking at actually using computer vision. They looked at the Unify Unify images for that study, and then looked at actually the computer actually looking at doing the whole colonoscopy, and the computer actually visualizing the whole colon, and then actually assessing disease severity based on the whole colon, and sort of scoring it based on that. And what they found was that it was that they could actually, during this, they could actually then reduce the number of, so you don't just look at one part, you actually look at the whole, and this is sort of shown down here on the right, and the last graphic on the right. They could actually find that by doing it, looking at the whole colon, the projected sample size you require to have a look at a difference in therapeutic difference between a drug could be significantly less, because they actually can judge the whole colon. I mean, anyway, this is obviously early days, and we only really brought this in because it's exciting and it's sort of a window to the future. So that's the end of the section. We'll go on to questions now. We're going to talk, what I might do is just, we'll have questions, and then I'll come back to the take-home slides. So do we have any questions? Miles,
Yeah,
I'm having trouble.
Sure,
Great.
sure. I can read out the question, Susie.
Yeah, great.
So
Thank
the
you.
question from Astrid Williams. Astrid's question was regarding the post-op recurrence and intra-abdominal septic complications Cleveland study. Was there a potential for bias for patients not being started on post-op preventative therapy, including with biologics, because they had a complication?
Absolutely.
And the second question was any suggestion with timing of post-op therapy in the setting of sepsis? How long do we have to wait?
Well, those two questions. One, I think yes, there was a bias because there was sepsis. Presumably the biologics were delayed. And secondly, no suggestion about when to do it in terms of timing, in terms of this particular study and what was discussed in the abstract. So no, neither of those questions were actually answered. I think I felt the take-home message also more from it was also just trying to prevent post-operative sepsis, being aware that those patients that are more at risk. And I think that was why that occurs, was kind of also what this sort of study raised. Is it something about getting sepsis which changes the microbiome in itself? But anyway, yeah, it didn't. Those two questions, Astrid, weren't really answered in this particular study.
And then the second question, Susie, you might be well placed to answer this, is from Rishi Sud. And Rishi's question is, a game changer for our patients with moderate IBD would be easier access to biologics without jumping through PBS hoops. Any chance of this happening in the future? It's a great question, Rishi.
Yeah, it's a great question, Richie. Yes, absolutely. I think yes. Gosh, no idea. Look, I think the next step is going to be try to reduce the burden of actually prescribing biologics and IBD and advanced therapies. That's going to be the next step. I don't think we're going to be able to, the hoop jumping I think is going to be further away, but I think trying to reduce the burden, and I think we obviously try to quickly escalate through immunomodulators onto biologics and those people with high risk, and we all know ways in which we can do that. So that sort of side of it, I think, is easier to manage in a way, but I think the burden of actually having to prescribe advanced therapies and biologics in Australia at the moment is ridiculous in terms of the amount of administrative work that's required now, and I think we're going to push harder for that. And there's been a recent change in the rheumatology. PBAC's just recommended that in rheumatology that there should be streamlined coding for biosimilars and the originators, I think, for in anti-TNF agents. So I'm going to look more closely at that and try and see if we can get CCA and GISA to work harder to try and reduce the burden in that space at least, because it is ridiculous.
I might just make a comment there, Rishi. We can, for perianal Crohn's disease, we can go straight to an anti-TNF, but otherwise we can't, do so-called oversimplistic top-down therapy. But we can after 3 months. And you've usually got 3 months, and I think implicit to us is just getting patients onto other conventional therapies, i.e. immunomodulators straight away. And I think most of this audience would know to avoid cycling through steroids.
Yeah, and I think that's right. I think we've still got a huge number of people that are just on steroids and don't get onto, and I think just the idea that you've got to get onto, immune modulators quickly, and then obviously very quickly move on to advanced therapies. I think, we're all speaking the same language essentially. The other thing I thought was interesting, is going to be interesting just in terms of small molecule discussion last night, Miles, is where the mods end up fitting in terms of where they fit in terms of the UC, positioning in the UC space, and that'll be really interesting to sort of see where the PBAC comes down later in the year in terms of in terms of the access to that. The small
There's a
molecules, I think,
related
where they get.
question,
Mm.
Susie, from Shomadat. Any hope of the PBS approving escalation via the PBS rather than the current complex situation of
Yeah,
compassionate access?
well, do you know what? I think Crohn's Colitis Care Shome is going to help us very much in that space to make that argument. I think the first step is to try and reduce the burden of paperwork, and then I think the next step then is to talk about stopping all this. I think we do that step first, and I think, yeah, like everyone's on the same page, escalation and actually titrating according to patient need and dosing, like you do with a lot of other drugs. So I think that'll be the next argument. I think we just have to do one thing at a time. But I do think things like the prospective data, which you're doing with Crohn's Colitis Care, is going to help make that argument over time as well. But one step at a time. We're all on the same page. Yep.
There's one question, and this is from Joe Chen. There are more options of biologics and small molecules now. How do you choose and counsel patients on the options? That's the million-dollar question, Joe.
Million-dollar question.
That's a 1 hour presentation in itself, Joe, I reckon. It's a bit hard to answer that one quickly, but I think that there's a number of things that you do ask. You want to know about safety in your patient population. Are they someone elderly, comorbidities, etc.? That's important in the choice. You want to know about your phenotype. Obviously, perianal disease, acute severe colitis have got their own drugs that work best. You want to know about their previous drugs, what they've been on, if they've failed immunomodulators. So you're thinking, well, they're going to need monotherapy. You're probably not going to go to an anti-TNF. You've got to think practical things as well. Do you want a tablet? Do you want a subcut? Are you happy to come to hospital for infusions? That comes into it. I think there's a whole heap of things, Joe, that on that one. Joe, I've got to talk. I'm very happy to email you on that one. If you can just grab my Alfred email, shoot me an email, I'll send you some slides through that.
I've listened to your talk about 5 times on that. The one you presented at AGW last year was an excellent talk.
But feel free to reach out, Joe, because it's a complex one and it's an evolving thing. But maybe getting back to Susie's point there of where are the small molecules going to fit in. I mean, we showed some data last night that maybe we should be starting to think about them in ulcerative colitis after we've failed our first biologic, rather than going to multiple biologics with a law of diminishing returns. That's a generalization. There's some patients will want them first line. There'll be others where multiple, a second biologic might be appropriate. But I'm starting to feel that that's where the small molecules are consolidating in UC as a generalization.
I think the other thing also, though, I think is, to your point last night, Miles, is around the issue of safety, and I think that's also going to play out a bit with the small molecules. They are sort of a broader immunosuppressive agents in some ways, and I think there are some safety things we've not been used to before, although the data so far is very reassuring. I think there's some that we're going to have to the real world data obviously is evolving, but the small molecules and upadacitinib, of course, is, there's all these drugs that are coming out, and there's some signals which we don't completely know yet how important they are in terms of new molecules, which I think obviously real world data will help us inform us in terms of where we position different drugs. And obviously things like extraintestinal manifestations, etc., also influence drug choice.
Absolutely. Susie, I'll make 2 comments on that. I completely agree. And I think, to pick up rare but serious side effects, you're not going to do that in a 1-year clinical trial of 800 patients, but you're going to get that in your post-marketing surveillance registry of 10,000 patients out to 10 years. So we do have to watch this space carefully with the small molecules for safety, and the issue with them is safety, it's not efficacy. But a comment that I would think, if we were sitting here looking at this new small molecule called azathioprine, or this new small molecule called methotrexate, or this new small molecule called prednisolone, we would be a lot more concerned about those safety side effects than what we're seeing with these newer molecules. We've got to put it in perspective of what we've got. Every IBD drug is a small molecule or a biologic. They're one or the other, and we've got to put that in that context.
I think azathioprine, I'm actually a big fan of methotrexate. I think it's a great drug, but I know it's safety anyway. Yes, no, I totally and utterly agree with you. Actually, I think they haven't had, and particularly steroids. I mean, if you think about the side effects of steroids, it probably wouldn't even get through PBAC actually. Nowadays, it really wouldn't, because of the side effects and etc. Anyway, yeah. And any other questions, Moss?
No other questions, Susie. Do you want to?
Oh, wonderful. Do we wrap up? I might just wrap up here.
Yeah.
And look, just a reminder to come back to the 3 take-home messages that Miles brought up last night. Firstly, the SPARE study. So although infliximab withdrawal is associated with high rates of relapse and immunomodulator withdrawal, and he obviously presented it tonight, when patients that relapse, when they've had steroid withdrawal, infliximab withdrawal, they achieve rapid remission in the vast majority of patients with infliximab retreatment. In fact, all these studies were presented today, actually now, and of course, Ernest's study as well, vedolizumab being the first biologic to be shown to be superior to placebo in chronic pericarditis, both for endoscopic, clinical, and histological remission. And finally, REM switch, looking at intravenous infliximab switched over, and particularly in patients who are on dose-escalated intravenous infliximab being switched over to subcutaneous infliximab, and relapse rate being reassuring, except in the patients on higher escalated doses and elevated fecal calprotectin. So they are the take-home message. And I think the other sort of take-home message we talked about last night as well was around the small molecules and longer induction in some patients, and also being able to stop and start.
Thanks, everyone. See you. Have a great night.
Bye-bye.
Hope to see you soon. Bye-bye.
Yeah, hope to see you soon. Bye-bye.